Connective tissue disorders, module 4, lecture 7. This is going to be part A. Connective tissue has many components. It is important in holding tissues together. Abnormalities in any of the components can result in weakness of the tissue. Connective tissue is important in cells and fibroblasts, chondrocytes and cartilage, osteoblasts and bone and osteocytes. It's also important in the extracellular matrix, including fibers, proteoglycans, glycoproteins, as well as tissues and tissue fluids. Collagen is one of the main components to connective tissue. There are over 25 genes which code for a variety of different types of collagen. Collagen is important in the strength of bones, joints, as well as the vascular system. In addition to collagen, there are a number of other genes important in tissue structure. Abnormalities in protein structure in any of the components can result in weakness of the tissue. Classic disorders of connective tissue, the most common is, osteogenesis imperfecta. Later, when I talk about other connective tissue disorders, I'm also going to discuss Marfan syndrome, Loeys-Dietz, Ehlers-Danlos type 1 or classic, and Ehlers-Danlos type 4 vascular. So we are going to just be dealing in this particular module with osteogenesis imperfecta, or connective tissue that affects the bones. Osteogenesis imperfecta is inherited in autosomal dominant fashion. It occurs in approximately 1 in 20,000 live births, and there are different forms of this. Type 1, there's fractures, blue sclera, normal life expectancy, and relatively normal height. Type 2 is a perinatal lethal with a recurrence risk about 5 to 6%. Even though this is lethal, and so you would think that it was something new that wouldn't be inherited, in rare occasions, one of the parents carries some copies of this abnormal gene in a percentage of their cells, but are unaffected. Type 3, short stature, limb bowing, and multiple fractures. And type 4, normal sclera. Sclera is the whites of the eye, fractures, osteopenia, and mild in severity. So let's talk about type 1, which is the most common. Patients have fractures, osteopenia or weak bones, blue sclera, and here's the sclera. You can see instead of the eyes looking white, they're blue, and here's another blue tinge. The reason that they look blue is because when you're looking at the eyes, you can see all the way to the back. Hearing loss is another common finding. Basically, there's over 100 bones in your ears, and there's increased risk of fractures, and so that's the reason that there's increased risk of hearing loss. Osteogenesis imperfecta type 1, this is the most common type. Bones fracture easily, bones are osteopenic, and again, near normal stature with joint hypermobility. So again, this collagen affects the bones and the joints. And that blue tinge at the back of the eyes. They can also have dental problems, and they usually have hearing loss in the 20s to 30s. Most fractures occur before puberty, and I'm going to discuss why that is. Osteogenesis type 2 is a lethal perinatal. So this is, the babies do not survive birth. They have fractures prenatally. So while sitting in a water bath, they can have fractures. They also have a very small chest wall. When looking at what we call skeletal dysplasias or problems with the skeleton, the determination between lethal and non-lethal is how big the chest wall is. Can the baby take the first breath? And in the case of this type 2 or lethal osteogenesis imperfecta, all these fractures result in pulmonary hyperplasia. The lungs were not able to develop, so the baby can't breathe once it's born. And they also have very severe small stature. And you can see how deformed these limbs are. You're not supposed to have bends like this. This is because multiple fractures prenatally. You can see how many times this femur is fractured here. Osteogenesis type 3, very small stature, fractures common at birth. And here we have a baby with 2 fractures, severe early hearing loss, and loose joints and poor muscle development. So here's this baby's hand, but you can see that this baby's not on a ventilator. They actually have kind of a barrel chest, and that allows them to for the lungs to develop. But when a baby goes to the birth canal, that can really increase the risk of fractures. And in fact, prenatally, if there is concern that there may be osteogenesis imperfecta, whether the bones look abnormal, weak, maybe small fractures, is it type 2 or is it type 3? The real determination is, what does the chest wall look like? The delivery for this particular baby would be much different if the baby was not deemed to be viable. C-section probably wouldn't even be recommended, whereas this baby would have a C-section with a very large incision to prevent any kind of fractures during the delivery process. You would never want this baby to go through the birth canal. Genes associated with osteogenesis imperfecta, or OI, there are 2 genes known to be associated, collagen 1A1 and collagen 1A2. The mildest form results in a stop codon or deletion, resulting in no collagen formed. If you recall, when we talked about cystic fibrosis, the most severe form of cystic fibrosis is when there's no gene, product. But in this case, the mildest form is when there's no gene product. During times of rapid growth, however, there's only half the amount of collagen that we need, and so the bones are weak and break. When an abnormal collagen protein is produced, however, the abnormal collagen is actually a more severe phenotype because of the abnormal tensile strength. So I want to go through what I mean here. So here we have 2 genes, collagen 1A1 and collagen 1A2. And in bones, as I said, there's 25 different types of collagen. And so these are the 2 that are important in bone strength. And there are 2 copies of the collagen 1A1 for every 1 copy of the collagen in 1A2. And 3 copies, 3 of these proteins get together and make a 3D structure like a rope. And this rope gives a tensile strength for bones. Now, in the mild type 1, what happens is we have the normal amount of collagen 1A2, but a less amount of the collagen 1A1, or 1A1. So instead of having 6 copies, we only have 8, we only have 4. So we have 2 copies here to 1 here, and we make our nice rope, 2 here to 1 here, and we make our nice rope, and we have a couple extra copies of the collagen 1A2 that doesn't have anything to do, so we just degrade it. So the good news is we have a normal collagen that has tensile strength. The bad news is we only have half that we need. And during times of rapid growth, that half probably isn't enough. And that's why the bones are so weak and they fracture. In contrast, here is types 2 and 3 and 4. We get protein, but it's not normal. So we have normal here, the black, and abnormal protein is made here. The problem is when we take a normal copy, an abnormal copy with our collagen 1A2, this does not hold together. This procollagen kind of falls apart. And as a result, we have no tensile strength. So in this case, we're better off with a stop codon that results in no protein than protein that kind of has kink in it and it doesn't hold together correctly. So we're going to end here, and I will move on to the Ehlers-Danlos and the other connective tissues when we talk about joint hypermobility.